So I'm here again in New York with Dr. Kenneth Brookler, a skull-based surgeon and otorhinologist. You?
Neurotologist.
Neurotologist. Oh yeah, and
Probably in the UK they probably say otoneurologist.
yes, exactly. And we were here last August and we had a fascinating discussion. So we might pick up where we were last time, approximately. We talked a lot about insulin, obviously, and insulin dysfunction that you've done a lot of work on over the last few decades. And since last August, you're focusing even more on low carbohydrate diets, and I think we talked about tinnitus as well. And since then, you're seeing even more effects.
Right. Well, actually, the discussion we had in August was a trigger for me to look into all of this because I thought at that time I was just telling you about my experience, not realizing the implications of it. And so I started looking at some of your YouTubes and some other things that you had recommended and started to work out the science of the low-carb, high-fat diet, which made a lot of sense, and started to talk about it to friends and relatives and got really quite interested in it so that it became a focus of a lot of my thinking in relationship to just general health and specifically for people with inner ear disorders that I had looked after in the past and started to get increasingly involved with the concept. And the interesting thing was somebody that commented on that YouTube from August who apparently had tinnitus, watched the YouTube and went on a low-carb, high-fat diet. We don't know exactly what it was or where he found out about it, but he wrote into to a comment on this to say that he watched this and his tinnitus went away. So that was kind of an interesting beginning to what happened with our last discussion. So looking into it further, it became clear to me that the medical profession basically doesn't really understand this. And as a result, I got interested in making sure that as many medical professionals would know about this, and I started to look into a possibility of actually beginning continuing medical education set up here in New York County, where I happen to be a past president of the County Medical Society and began exploring that possibility. Subsequent to that, I through my wife, who offered my services, although in retirement, for a friend whose sister-in-law had severe Meniere's disease and was having spells as frequently as 3 times a week. So my wife offered that I would speak to this woman. And so I did speak to her, and by history she did have Meniere's disease. And in further talking to her, I suggested maybe if she'd had some recent blood tests, that if she could send them to me, and I would look at them. And so she did, and she did eventually get them to me, and she had a fasting blood sugar of 126. She had been on a diuretic, which is commonly used to treat Meniere's disease, and it can cause all kinds of changes in the sodium, potassium, and chloride, which she had, which were off the normative levels. So in spite of the fact that when she first went on the diuretic and she felt better, I was able to tell her that I think that the diuretic isn't helping her anymore, and that I thought if she did a search on the internet for low-carb, high-fat diet, she would get some ideas about entry-level diets. And also, since I had this discussion with you in August, I interested my daughter, who's a nutritionist, in this, and said that my daughter might be willing to speak to her to give her some pointers. So she did follow the advice, and the spells that were 3 times a week diminished, and within 3 weeks they were all gone. And that would be, I think, around the middle of January. And so now we're sitting here in the middle of April, and last email communication with her, she's still free of her dizziness. So that was somebody who benefited from this just from a conversation. Another patient who'd been a patient for many years, whose dizziness was controlled with a diet that at that time was low carb, but it was moderate protein and low fat, because those were the dietary recommendations at that time. And this particular diet amounted to 3 low carb meals a day with a snack between meals and between dinner and bedtime to kind of maintain the glucose level. And this had sustained her symptoms, although she would periodically develop a headache that's not unusual coming from the balanced part of the inner ear. And periodically she got in the habit of treating this with some low-dose Valium. And also she would use Valium at times to get over jet lag from trips across the ocean and things like that. In December of 2013, she had the first of 2 cataract operations, and what the first operation does is it produces an unbalanced vision between the operated eye and the unoperated eye, and it is through the eyes that the brain compensates for balance disorders. And it was likely that she was going to develop some balance disorder after the first operation, which she did. And I suggested that the Valium that she has a prescription for be increased to reduce her symptoms, which it did. She had her second operation and had a complication of that operation that required eyelid surgery. So all of this went over a period of a few months, and during that time she began to take a larger dose of the Valium. Once she was over with her eye problems, which took about 6 months, we then started to taper her off the Valium, and found that when we reached a dose of roughly around 5 milligrams a day, that she could not go below it without having more symptoms. So reaching into my toolbox and going back to really old literature, and with the cooperation of a treating physician, we started her on amphetamine, which is a suppressor of the balance system, and was able to slowly get her off the Valium completely. And we had gotten to this point by about August of last year when we last spoke in this room. And we were trying to figure out now how to get her off the amphetamine, which she of course had been on for a much briefer period of time. And so I suggested the low-carb, high-fat diet, and again in conjunction with some advice from my daughter, we were able to get her off the amphetamine, and also we were able to get her off the very strict regimen that she was on before that required the timing of that snack between meals. She had to carry food around all day, and all these other things kind of disappeared, and she is now functioning at a really good level, which is a kind of an interesting thing for me, because here we were controlling symptoms with a drug that could suppress the dizziness in the form of Valium by putting a cloud on the brain, and then introduce a drug like amphetamine to stop the Valium, which works on the neurochemicals involved in the balance system, but isn't really treating the problem. And here, with a diet like this, we could actually eliminate her symptoms, and without the need for any drugs, which was really wonderful and a good result. So, and I'm sure there are many like this. Unfortunately, I'm not practicing anymore to do this on a daily basis. Fast forward, though.
Well, I was going to say, but you are going. You have a lot of data from the last decades where you were practicing, which you can
right.
You may revisit in a sense.
Yeah, and actually, another thing I do is research at the Mayo Clinic in Arizona, and one of my colleagues is a computational scientist. And I realized also after that August interview that I had an experience that a lot of doctors don't have, including the low-carb, high-fat doctors that kind of triangulate the triglycerides with the cholesterol to decide whether there's insulin resistance. And I actually had actual numbers that I could look at. And I have preserved my patient charts and discussed this with my computational scientist colleague at Arizona, and I'm going to be extracting all of the information and have him, with his magic, figure out all these kind of things that may have been in these records for years. So I hope to unlock all of those things, and maybe within a year or so, because I hope that there will be at least 1,000 patients where I have glucose tolerance tests on, if not more. I don't know, because my electronic medical record was 10 years old, and I've been doing this for 25, almost 30 years. So I think that my hope is it's going to roughly be about 1,000 patients, and we're going to link that with their presenting symptoms and a lot of other factors that we're going to put into a spreadsheet and see what kind of information we get out of that.
That's going to be really fascinating. And of course, almost uniquely, I mean, you have all of these glucose tolerances with insulin assays, which are so relatively rare.
Right, exactly.
But now we believe are one of the most important tests data you can have for patients.
Exactly.
Symptoms.
And then in the current atmosphere in medicine, I think that the laboratories don't get much requests for insulins, and insurance companies don't pay for those things. Yeah. And so there's a whole other kind of problem. So I was interested in the triangulation of trying to figure out whether somebody's got insulin resistance without measuring their insulin. But basically I have all that data along with their lipid panels and all the other things to basically coordinate that information.
Excellent data set. And I think, you mentioned earlier as well, you're kind of coming across now doctors indirectly where you pry and you find out they actually are deploying kind of low carb, high fat.
Right.
I think a recent a friend of yours who had diabetes and.
Yes, yeah, exactly. So we when we're in Arizona, we have a friend that we socialize with because of our common interest in jazz, and it's always kind of been social. But then just about a month ago, on one of these jazz evenings, he said that his doctor put him on a new diet and he's using half the amount of insulin he used to use. And I didn't know he was diabetic to start off with. I've known him for 3 years.
Yeah.
We never discussed medical things with him. And so my ears perked up based upon all this new knowledge I have. And I said to him, and I asked him a few more questions, and I said, well, this has to be a low-carb, high-fat diet. I said, well, can you give me your doctor's name? And I was putting on an informational session for my team in Arizona that week. And so he gave me her phone number, and I gave her a call and couldn't really get to her until 2 days before this informational session. And I told her I was putting this on, and I was really interested in her whole approach and could understand all of this. And she said, I said, could you come on 2 days' notice and talk to our group? And she was quite happy to do so. As a matter of fact, she bought a box of books and gave them out to anybody who was interested, and they were the book by Dr. Bernstein and the Volek Finney book to anybody that came to this small session that we had. In addition, I was able to find in the Phoenix area Dr. Adrian Scheck, who does research at the Barrow Neurologic Institute, and she has a strain of mice that produce astrocytomas that she's been treating with the ketogenic diet, and she also is involved in the clinical side, where in patients where there is this diagnosis, they've randomized the patients to a ketogenic diet and to a regular diet to see if there's any difference in the outcome. And she's also been involved to some degree with Mr. Scarborough, who you're very familiar
Andrew,
with.
Yes.
And so she was able to speak to our group at that time.
And that would be parallel with the work of D'Agostino and Siegfried and Professor Fine. And
right, exactly.
All of these guys were breaking into this.
On the cancer side, right.
Yeah, absolutely.
Yeah, and so also part of what I do when I'm in Arizona is think about things, and so I'm starting to think about the use of ketogenic diet for concussion. Clearly, there's more about epilepsy. I always thought it was more for the pediatric or juvenile epilepsy, but it looks like it may also have an application for the adults. Also, there are some papers now that suggest that some of the dementia could also be actually related to this and treated by a low-carb or ketogenic diet.
Yeah. So there's huge scope.
Yeah.
I think we talked as well about, with all this emerging science, in a sense it began to emerge really decades ago, but it's, should I use the word suppressed? I mean, in a sense, it has been suppressed. So
I think buried is it might be a better word.
Yeah,
than
like
suppressed.
Yeah, I'm trying to be as fair as I can. But yeah, buried would be the Minnesota experiment, the Sydney heart trial, the Helsinki businessman's. So much science was kind of buried because it didn't fit with the fat is bad paradigm. But it looks like now we're really getting a critical mass. So I'm guessing the next few years, maybe this whole thing was going to turn around, but there's still a lot of resistance.
Right, and actually, my Arizona connection also has a collaboration within the Karolinska Institute in Stockholm, and so one of the our collaborators was on site for about 3 weeks. I had a long talk with her about that, and apparently they're aware of it in Sweden, but it hasn't yet it hasn't been fully implemented, but a lot of the people are fully aware of the low-carb part that way. I found that kind of interesting on talking to her.
All right, in Sweden, well, Sweden actually, and some viewers will be well aware, Dr. Andreas Einfeld, who runs Diet Doctor, basically in Sweden, they're probably the leading country in the world because they have gone through a whole process where a doctor who discovered low carb many years ago applied it to herself, got massive benefits, began to apply it to her patients. A dietitian's council perhaps challenged and asked her to be censured, and they had a 2-year process with government scientists, 20,000 papers reviewed, and they came out in Sweden with the conclusion that a low-carb diet is probably the best for overweight or diabetic people. So I think there was even a butter shortage in Sweden. Yeah, there's a whole fascinating story behind that.
Yeah, that was kind of anecdotal. She was just there for 3 weeks on site with our collaborative work, but I got a chance to interact with her and find out about that.
Yeah, and they've got an awareness.
Yeah.
And just to cut actually to, I know, and I haven't had time to talk to you much in the past months, but you've kind of switched a lot of your research now towards the endoplasmic reticulum, which is a constituent of the cell. Maybe it'd be interesting just to touch on some of that work and the insights you're getting.
So about 6 weeks ago, I found a paper on insulin affecting the endoplasmic reticulum of the hippocampus, and I was familiar with that because of the tinnitus work, because a lot of the patients who are really troubled by their tinnitus, there actually are signs on MRI of something going on in the hippocampus, which goes into the amygdala where our emotions are, and these other things occur. And so as I looked at that, I said, gee, a high insulin level causes what's called endoplasmic reticulum stress on the cells of the hippocampus. They can then affect personality and all kinds of other things related to that. I said, well, there must be an endoplasmic reticulum someplace else. I kind of remembered it from my medical school days as kind of being part of a cell and didn't really understand. But since then, I've downloaded almost 200 papers of endoplasmic reticulum in every cell in the body that has a nucleus, except for a red blood cell that has no nucleus. And of particular interest is the endoplasmic reticulum stress of the beta cells of the pancreas with a high insulin. And what that does is it causes a stress in these cells, and the effect of the stress is for the cells to put out less insulin. So what would then happen is the blood sugars would still signal the need for more insulin, and so what would then happen is the cells will be pushed to produce more insulin, and I think that this may be part of the beginning of insulin resistance. And then it appears, and I'm not sure because I don't know if enough research has been done, and a lot of these papers have only come out in the last 2 years about endoplasmic reticulum stress in other cells in the body caused by insulin. There are other ones that can occur, and when you start to look at how the stress actually works on the cells, the cell can actually go to basically die or have apoptosis, or go on another stream to function differently. One of those streams could be as a cancer cell. The other could be in terms of an autoimmune process or some other change in the way the cell works. And then on top of all of that, the endoplasmic reticulum feeds into the Golgi apparatus, and more specifically the mitochondria. And in my world, that is of the inner ear, the mitochondria are basically what produces all the energy in the inner ear that allows the inner ear to basically react in micro nanoseconds to anything that's going on that stimulates it. In order to do that, it has to produce a huge amount of energy, and I think all of this is basically tied in and is going to be a focus of a lot of things that I'm interested in going forward.
Yeah, it sounds like even though the physiology is so complex with so many feedback loops, that endoplasmic reticulum may have a very important part, being in every cell in the body affected in the way you described by insulin. And just for people to maybe just a simple explanation, the endoplasmic reticulum is the kind of powerhouse of the cell to fold proteins and create,
to replicate itself so it can go on living.
Yes, exactly. Yeah. And so a really crucial area, which I haven't really heard talked about much before until you've been digging this up in the past 6 months.
Oh, and there's lots of stuff there available, and I'm just starting to go through all those papers.
Yeah, I'm sure some fascinating stuff is going to emerge from that.
And then to top all that off, just a week ago I went to a lecture on white and brown fat. And the effect of how fat may actually have an effect on insulin. And so when you start to think about insulin and glucagon and how glucagon causes gluconeogenesis that can occur from fat and from liver, and if fat can also do something to insulin, there's a whole kind of signaling process that I think is going on that we're going to have to try and understand, and then how we basically change that by introducing the diet.
Yes.
And then how that diet changes things by affecting the microbiome, which is another thing we need to look at. And then my whole other world of bone, the concept of bone acting as an endocrine organ. So all of these things are all in some kind of balance in a normal person. But when somebody is not normal and you want to try and change it or improve their health, how does all this come about? So it's going to be an interesting journey.
It will indeed, and the complexity will be huge. But in most complex systems, I think there'll be broad primary drivers of dysfunction or broad primary drivers of improvement, even though the system is so complex.
Yes.
And I think that's where the low carb, high fat, combined with, magnesium deficiency, vitamin D, and there's probably 5 or 6 or 7 key elements that are the first to tackle to try and influence that whole complex system.
Right. As a matter of fact, I was just reading today that apparently the winter grass may not have as much magnesium in it to feed the cows, and so it actually just came out in something I was looking at today. And then we also know from the magnesium side that you mentioned that there are certain areas in the world where there's less magnesium in the ground, and it doesn't get replaced when we're growing grass or any kind of other nutrients. So it needs to really be focused upon because it's an important element in the body.
Very much so. So anyway, I know we're tight for time now because we have to go and meet Professor Feinman, Professor Fine, and Antonio Martinez, and I think your daughter is coming along as well.
Right.
So I'm sure we'll have a really intellectual discussion.
Should be a great
with guys like you. I'll just listen and learn.
Oh no, I'm always learning from you. You started me on this.
Well, you're the one who'll take it somewhere. Lovely meeting you again,
Okay, thank
Ken,
you, Ivor.
and thanks very much. And
Pleasure.
We'll be back again.
Right, I'm
Cheers.
sure.